The following are 3 case presentations in orofacial pain. This material should enhance your knowledge learned in the facial pain modules. Thank you.
Good morning, everyone. So I'm Adeline. Okay. So I will present a case of TMD problem. So these are the contents of my presentation. We start with the history of my patient. So Mr. C is a 53 years old gentleman. He came to Ajit's consulting clinic in February 2015 with complaint pain at both the MJ area, but it's more on the right side of the jaw, involves the eyes and also the ears. So it's been there for more than 20 years actually. So I think he came to our clinic just to see what we can have, what we have to offer for him, what we can offer for him. So it's spontaneous onset with no specific pattern. There is constant dull ache and sometimes there are episodes of sharp pain. And he said that he felt the pain is always there and never resolved, and there are times that it gets worse. The pain intensity is around 6/10 when it was the worst, and sometimes it affects his daily activities. So this is one of the things that are included in the proforma that we use during our history and examination. So for the medical history, as you can see, he has gastric reflux and hypercholesterolemia. He's taking medications such as omeprazole and statin. He is a social drinker and an ex-smoker. So continue with the history. For dental history, he is a regular attendee at dental school. He has multiple treatments done, such as restorations, endodontic treatment, extractions, and fabrication of an immediate upper full denture. And he went to multiple clinics such as the GDP, the MG clinic, oral medicine, and also UCU to seek treatment regarding his pain problem. He had complaint of pain of the lower jaw even after endodontic treatment had been done for the 3-5 and 4-5, and also pain even after the 3-6, 4-6, and 4-7 extracted. And also fabrication of intraoral appliance has been done for a long time ago, but he hasn't been wearing it for a few years now. And currently he is wearing full upper denture. So this is the proforma for the pain history. As you can see, it's like what I described before, the location of the pain, which is the onset of many years, and is presented as a dull ache and sometimes sharp pain. The intensity is 6/10 most of the time and distributed on the right side of the pain. Also involve the bilateral TMJ. And then the comorbid, but he doesn't have any comorbid depression, some GI symptoms such as gastric reflux. So since it's been going on for more than 20 years, so it's considered as a chronic problem. So for clinical examination, generally he doesn't have any problem, but for extraorally, he has muscle tenderness of the masseter and pterygoid, but the mouth opening is normal. For soft tissue examination, no abnormality detected. And then the findings, he is wearing a full upper denture with good retention, but the acrylic teeth is slightly wearing off. The teeth that is presented is 3-7 and 3-4 until 4-4, and there is some gingival recession of the posterior teeth. So when we look into further for the pain, extraorally, you can see that the pain is around 4 to 6 for the extraoral masseter, TMJ, and pterygoid. And intraorally is also around that area, that score for the masseter and pterygoid. So, but the mouth opening is normal and some signs of wear of the lower teeth. So for investigations, we just do an OPG for him first, and this is what we got. So generally, this is an OPG of Mr. CS. You can see both of the condyles are in good shape, in good location and condition. Sinus seems normal. There is no pathology of the mandible. There is a horizontal bone loss, especially for the posterior teeth. You can see a small caries of the 4 to distal, and it might seem like a periapical pathology, but it's not well circumscribed. Might be artifact, can be significant or not. So the summary of this patient is Mr. CS, a 53 years old gentleman, complained of bilateral TMJ pain for years and currently is more prominent on the right side. And with medical history of gastric reflux and hypercholesterolemia, on medications. And on examination, there is TMJ pain and muscle tenderness of the masseter and pterygoid. And OPG showed no insignificant finding. There is no significant finding. So before I proceed with the diagnosis and others, we can see the classification of the orofacial pain. So this is what Ajit had showed us this morning regarding the pain can be from dental alveolar, oral mucosa, neurovascular, or musculoligamentous. It's simplifying these things. We can divide into these 3 categories. So for the dental alveolar or oral mucosa, which is most probably what we usually see in our clinic, these are the reasons of the pain. And neurovascular can be divided into neuropathic pain, primary headaches, and other types of pain. And for muscular ligamentous, for TMD disorder, this is the RDC TMD classification, and there's also the DC TMD classification. So what is diagnosis for this patient? We diagnose him as having temporomandibular disorder, which is TMD. So the treatment plan is start less invasive treatments. So we give reassurance, self-care instructions. So we advise inform the patient that what problem that he's having right now and how to cope with the pain. And it's not a short-term fix, meaning it's not that from this appointment he will be fixed, he doesn't have any pain. So that's just right. Not a really good thing to see for the patients actually. And what are our treatment aims for this patient? And then do the needed restoration, intraoral appliance to be worn over the full upper denture at night time, and also review. So as you can see, this is his denture, and he's actually wearing the appliance over the denture at night time. So currently, I advise him to wear around 6 times for 1 week. So he has 1 day off from the denture and then the appliance. Okay, so our treatment goals for this patient is managing or reduce the pain, improving his function, and also the quality of life. So what is temporomandibular disorder? It's pain affecting the masticatory muscles and or the TMJs. So it usually affects female and consists of muscular or myofascial pain, TMJ disinterference disorders, and also TMJ degenerative disorder. And TMD can lead to other chronic conditions such as headaches, migraine, PTSD, and fibromyalgia. So we have done the treatment for him, like the stated slide before. But what is the current problem? He came to the special care unit in July 2015. So the first time we saw him was in February. So in July, he complained of pain of the right mandible for 2 weeks, for the past 2 weeks. He said that it's dull and throbbing pain and does not really resolve by painkillers. And the patient said that he had been wearing the intraoral appliance since March 2015. And he claimed of having a pain-free period for 1.5 months. He was happy with that condition and he even went on a holiday. So it was a really good time for him for that 1.5 months. And he said that he had pain again. And now he said that sometimes he feels frustrated with the pain because it doesn't resolve. It doesn't do any good for him. But he said that, knowing that he had missed his recall appointments after the appliance was delivered. Okay, so we call him again, and the treatment that we done is we trim the plane of to make the occlusal appliance a flat plane, check with the articulating paper. And then he commented that it feels more distributed on both sides compared to previous condition. So this is what he told me. And then we reinforce on self-care instructions for him. And then the plan is to review him every 6 weeks for symptoms. And then he came to special care unit in September 2015 for review. He said that the pain is still present, but it's more tolerable. He is still wearing the appliance, and he has more good days than bad days now. So the discussion for this case is, we knew that TMD is not directly related to occlusion because the patient had pain since 20 years ago when he is fully dentate. And now he is wearing upper full denture. He also have pain after extractions and currently. And then we have to emphasize the importance of recall appointments. So it's not like after we do any treatment, actually, they just can go home and forget about it. So why it's important for the recall appointments is to review symptoms and also adjustments of the appliance if needed. So the management for this patient, we look into neuromodulation, which is central sensitization by using the appliance, cognitive behavior therapy, giving the patients how they can control the condition, what is expected, what is the aims of the treatment, physiotherapy, and role of clinicians, which means that we can provide a safety net for patients. They know that if they have problems, because it's a chronic problem, they can come to us. So it's good if we have a really well-structured clinic for this condition. But anyway, and looking into the appliance, intraoral appliance, there is a research of the randomized control trial saying that heart stabilization appliance, when adjusted properly, have good efficacy in managing the MGD pain. And there are other types of appliances, but it has potential side effects. So as a conclusion and take-home message, TMD is a long-term chronic problem. The aim is to teach the patient to cope with the disease, manage the pain, improving function and quality of life. And a multidisciplinary approach can provide a higher level care for this kind of patients. So,
I have a question. So the treatment is sort of obviously wearing the plate at night, which obviously works quite well. But have you found any issues with soft tissues?
No, that's the importance of reinforcing denture hygiene for this patient. It's more important for him because he's wearing it for quite some time. Yeah. Compared to some people that they take it out at night time.
Yeah.
So in a way, currently I'm advising of using 6 days per week, and we're looking into decreasing the days of using it. But otherwise, he's quite okay. Everything is clean and no problems.
Do you think also, because he sort of mentioned good result for a month and a half following the splint, do you think by just changing the inclusion a little bit, you can sort of prolong that? As obviously that's what you've been doing. Do you think that would?
I think it's a bit of everything.
Yeah.
With the when the first time he came, we said that this is his problem. This is what is the problem. What is our aim of treatment? It's not just giving an appliance and this is how we manage it. So it says that maybe that's the first for him. That's the first time that he thinks that he can, boss it or something like that. But then maybe the appliance also help. It's a bit of that's one.
I suppose just a comment on that if we know or if we believe the fact that occlusion hasn't got anything to do with the pain issue in these patients, TMD patients, and we do also know that these intraoral appliances work, and if we also put the information in that there may be a central issue going on, our medications work as Professor Farrell talked about with the synapses, the blocking the blocking things at the synapses, and that's basically similar to a gate control. Okay, and the possibility is that these intraoral appliances create a sense of neuromodulation body. So when you're changing the occlusion, that's what it's doing.
Yeah.
And what we're trying to do is break that pattern for the patient. So that's the reason why it's very important that these patients are reviewed regularly, even if it's improving. I normally get these patients back until we get some improvement first on a very short, regular basis, and then we prolong that, and then we may prolong that eventually if things are going really well yearly. I'll probably review those patients for a couple of years, but I know that management is actually working because for exactly that reason, that anything we do can actually have a temporary improvement of what you want to make sure that this is going to be long term. Plus, it's also creating support for the patient in that initial management phase. They know that you've got the clinicians there, you're guiding them through that. That's common behavior therapy reassurance.
I have a few questions about these patients. You mentioned there was a tenderness to palpation of masticatory muscle. Was that pain familiar? So were you able to reproduce the pain complaint when you were palpating the jaw muscle?
No, I did the palpation. He said that. I'm not sure if it's family said that. Yeah, it's painful like before. So, but I'm not that good of doing that. I mean, I'm still learning about it. So I think maybe it's the same thing that he's experiencing. That's the way his response to me.
And I have two more questions. You say that there is bruxism. How do you see that?
Oh, it's actually some wearing off from the teeth, but very minimal structure.
How was your diagnosis of bruxism basically for that? Because the process work was worn?
No, from the he has a natural teeth in the lower.
Yes.
Yeah.
And they were worn?
They were worn, but not really severe.
So your diagnosis of bruxism was based on worn dentition? Correct? So just to understand. And last question, actually I have many questions. It's quite atypical for a male to have masticatory muscle pain. Sure, the vast majority are women.
Yeah.
And at least I have to quote my experience. When men have the TMD, there may be some psychosocial issue. Have you got any insight in psychosocial or there are also some instruments to assess what is the psychosocial impacts of this man, something about his life. Was it a happy man or a happy man? Did you get any insights?
Yeah, I've asked for his family. He is still with his wife. So he said that not a direct question. He said that his wife prepared the breakfast, and he enjoyed the food. He had breakfast with his wife, and he is working in construction. But it's not really a job. He says it's not really stressful. He enjoyed his job. He really liked it. So that's a bit of an insight of his social life.
Also, in the time that you managed him, his pain has improved, and he seems happier.
He seems
So
happier.
therefore, if you found that that wasn't happening, then you would probably think about the possibility of getting someone else involved.
Yeah. But we have to be very careful, because when he's had the pain again, he said that he feels like it's causing a bit of distress.
You mentioned self-care. What do you mean by self-care?
It's more of an exercise, and not to open the mouth that wide. To hit
There's a
like
list that
this,
you can-
yeah, please look at it. For him to set an instruction what you can do and you cannot do.
Not the self-help thing.
But we can show that.
Yeah.
My name is Adel. Declan Dent, oral medicine, first year, and I'm presenting a case which I called elastic gear, between brackets EDS. So let's discover the story of the elastic gear. Okay. So my patient is GR, 19 years old, female. She was referred to us to TMJ clinic from the Student Health Center regarding pain on her right TMJ after dislocation. According to the patient, dislocation happened while she was eating an apple, and she managed to self-reduce the dislocation by herself without much pain, but she have this intense pain since then. She also reported that she have this problem for years now, which was basically she was managing herself. But since she had fell down on her face last year, she's starting to develop symptoms and signs of TMD. So this is the proforma we use in the TMD clinic, and so which shown here the previous medical history, and patients basically been diagnosed with Ehlers-Danlos syndrome type 3, which is hypermobility type, and along with that she have the complication of Raynaud's syndrome, low vision, and indigestion problem, low blood pressure, and she's taken Nurofen and Ibuprofen. Just touching on Ajeth's talk, that's seemed to be that's from the medical history that's she's actually on that category of patient of high susceptibility to pain. She's having indigestion problem, so she might fall in that category. Pain history, again, this is part of the proforma. Pain history revealed that pain is mainly on the right TMJ radiating to the right temporal and right ear, and it's chronic. It's been there for more than 3 months, and it's constant, and in good days it's intensity. It's 3 out of 10, and the bad days could go up to 8. Things which exacerbate the pain is hard food eating and yawning, and it's nothing make it better, basically. On TMD examinations, it's a lot of numbers in here, but the main thing is she's having, as you could see, pain from both muscle of mastication and the TMJ bilaterally, and mildly probably restricted mouth opening to 2.5 fingers. This is here OBG. It's not the best resolution, but you could see that she's fully dented and there's minimum restorations. It's probably the only two she's having a root canal treatment in centrals and upper centrals. Her sinus is clear, no bony pathology. Condyle, it's a bit flat, I would say probably. And this is something to mention in here. It's quite important for patients with Ehlers-Danlos syndrome that they have a good oral hygiene, so that they don't have, because it's quite challenging to treat them in the dental chair. So summary of our investigations: intraorally is nothing, no abnormality detected. OBG shows flat condyle, and our examination show bilateral pain from both TMJ and muscle of mastication, and restricted mouth opening because of pain. This has already been touched by Ajaz and Adlin, and this is the sort of puzzle we have to go through before we come to our diagnosis. And this is the shorter version, or SUI version, probably we call it. In my case, it's probably straightforward TMD case. So this is again touched by Adlin, and I probably emphasize more on the treatment goal. And we actually, before deliver our treatment to the patient, we kind of have to make sure that the patients understand our treatment goal, so they know that we're not aiming for zero pain, we're more aiming to reduce the pain and improve their oral function, and hopefully by doing this to improving their quality of life. And this is by itself, it works as cognitive behavior therapy, and on top of that we do conservative treatment, which is do's and don'ts, hot back, soft diet, and show exercises. And again, the intraoral appliance, the occlusal splints. Now we'll leave the case alone and go a bit more details in history of EDS. And the history started in 1901, where the first case was reported by Eller, a Danish dermatologist. And in 1908, second case reported by Danlos, a French dermatologist. And in the mid-30s, the term Ehlers-Danlos syndrome was given to these patients with these symptoms. In 1986, Perlin classifications came about with 10 types of Ehlers-Danlos syndrome. And in 1997, Villefranche classification was trying to simplify the older classification into 6 categories. This is the classification of EDS, the old one, or the Perlin classification on the left, and the Villefranche classification as well. Something to mention in here, that it's out of these clinical features, it's the only dental or oral manifestation which is regarded as minor diagnostic criteria is gingival recession. I won't be able to probably point in there. It's one of the minor diagnostic criteria of, sorry, I won't be able to do that. Yeah, it's in your gingival recession, which is is the only one diagnostic criteria for vascular type of the EDS. So signs and symptoms of Ehlers-Danlos syndrome basically depend on the type of the EDS. Prevalence, it depends again on the type of EDS, but it could vary from 1 in 10,000 to 1 in 100,000. What is more importantly is that all EDS have signs and symptoms of TMD that's based on the Coaster study done in 2005. Although the sample was quite small, 31 cases, but I guess EDS is probably a rare anyway. Other symptoms with EDS include skin symptoms like bruising and stretching skin, of course, joint hypermobility and dislocations, pain, vision problems, back pain, and full wound healing. Complications, again, of EDS could be divided into two. One is mainly appear in vascular EDS to do mainly rupture of fetal membranes during pregnancy or arteries rupture, intestinal rupture, and rupture of the eyeball. The other complications could appear in any type of EDS, chronic joint pain, arthritis, and failure of surgical wound to close. Dental manifestations, as I said, gingival recession is the only criteria that was mentioned in the Villefranche classifications, but other signs was reported in the literature as well. On the periodontium, aggressive periodontitis been reported, teeth mobility and mucosal ulceration, teeth, pulp stone, short roots or longer mandibular roots, and supernumerary hypodontia, and TMJ dislocation, pain, and clicking, popping. Others as well have been mentioned, Gorlin's sign, which is the ability of the patient to touch his nose by his tongue, high arched palate and crowding, and absence of inferior labial and lingual frenum. A bit more on the type 3 EDS, or the hypermobility type. It's considered the least severe and the most common type of EDS, and skin normally in these cases is mildly hyperextensible. And the common features on hypermobility type is joint subluxation and dislocations, chronic back pain, and TMD, vision problem, and psychological impairment. Other less common, it's a neuropathic pain, gastrointestinal symptoms, and vision problem. So going back to the case, I saw the patient after 3 months of delivering the intraoral appliance, and that was on the 3rd of September. And you could see the two charts, or the two pro forma before and after, and on the red you could see the score of the pain. We managed to reduce too many of these numbers to 0 actually on after delivering the splint, and probably the main reduction was more on the masseter and temporalis pain, and the left TMJ as well, and pterygoid. And on the intraorally, it's still the masseter, it's still 4 out of 10, and the lateral pterygoid. But in terms of, just going back to Prof. Marlowe, lecture is saying reduction of 50% is a success, so I thought this is probably more than 50%, which I regard as probably success. So in conclusion, my case was a young girl with TMD, history of recurrent dislocation, and of her jaw with a history of EDS. And it seemed to be that everyone agree that our take-home message is dealing with chronic pain has to be has different goals. So managing by the pain or reducing the pain is the main goal. Improving the oral function and by doing this, hopefully improving the quality of patients' life. Thank you.
I would like to have more information about the TMJ dislocation. How often did this occur, and what did you do to manage that?
Well, she was reporting that she don't have a problem with the dislocation because she's always self-reduced the dislocation, and she have this for years. She was diagnosed with Ehlers-Danlos syndrome since she was 8 years old, and I only see her and she's now 18 years old. And it's not only the dislocation of TMJ she's having, it's basically the dislocations of a lot of joints she's having. But she don't have any problem with that. It's only recently when she had an incident and then she developed the pain, but otherwise she's very good.
Yes, I'm saying that because once I saw a patient with this syndrome and the subluxation was resulting in luxation. So that means that in that case you have to do something to avoid the joint to be luxated. And, I did not know in that patients we just do a conservative management, that is making exercise with the tongue under the palate so they can increase the amount of rotational jaw opening. When they make yawning, they could use the hand to push the mandible back to avoid the luxation. But in some severe cases, you may also need buttocks injection into the lateral pterygoid muscle. But luckily, this is a rare condition.
I guess the issue here is you want to work out whether this is the impact of the Ehlers-Danlos on the TMD that she has had. But also some of the self-care instructions actually probably would help with the things that you're talking about with Ehlers-Danlos dislocations, because basically the advice that we're giving the TMD patients would benefit people that have got dislocations as well. These are the instructions there. There's some thing that you talk about the tongue and all that. I explain it as well. All right. Next.
So, good afternoon. This is the presentation before the last one, before lunch. And this is about double trouble, really. So I'll start with the case presentation, and you can see the rest of the outline of my presentation. And we have a 34-year-old lady. She's been married for 10 years, and she's got one child. And she was quite cheerful on the appointment day. She was accompanied by her husband, and she was complaining of pain at the left side of her face from the midline, almost the entire left face with involved. And this one the problem started since 4 or 5 years ago. The pain is currently constant, dull, aching in character, but she has severe pain twice a week, episodes of pain. And she uses ibuprofen to relieve the pain. So before we go on to our examination, we'll take a look at the history of the patient, and from 4 or 5 years, how did this whole thing start? And it actually started in March 2010, where she started feeling a small lump and soreness in the left side of her face in front of her ears. And it became sore. So she sought help, and in March, February, her GP had prescribed antibiotics, but she had an adverse reaction to that gastrointestinal disturbance. So she stopped that. So she was referred to the ENT clinic, and she was seen in conjunction with the oromaxillofacial surgeons. And this was the finding that she had a 1 centimeter left facial lump. It was mobile. It was tender as well. So they decided it was either a parotid neoplasm, a tumor, or a lymph node, a facial lymph node, which occurs commonly in that region. So they arranged for fine needle aspiration, ultrasound guided in cytology, but it was inconclusive. They said it's possibly a mucus cyst. They didn't see any neoplasm there. So they arranged for a sallogram in July 2010. Now, they tried catheterization of the parotid ducts, but they couldn't. They failed to do that. So they arranged for an MRI in August 2010. And the left parotid looked smaller than the right one, but there was no cystic lesion and there was no duct dilatation there. By that time, her symptoms were worsening. So they used Botox, and following Botox injections, her symptoms markedly improved. So they put her on 6-month follow-up visits and injections of Botox. Because
injection where?
In the salivary gland, yes. So but the parotid mass resolved in 2011, but there were still episodes of pain persistent. But by September, there was no tenderness, but there was just lump still there. And she had no complaint. But in October 2014, she started complaining of left facial pain. And this was severe, just like, episodic. And it was or wasn't related to meal times and eating. And this one got a bit worse. So it was radiating to her shoulders and the angle of the mandible and her ear. So the red boxes are actually when she was seen by the ENT specialists, as I mentioned earlier. So by then, she had enough, and she was offered, the option of surgery, partial parotidectomy, which she opted for in December 2014. The histology report was marked sialadenitis, which is the inflammation of the salivary gland with marked atrophy, which you do expect in chronic sialadenitis. When we were going through the files, we actually found the word neoplasm or tumor, so it was a bit, we had to see the report to see what the pathology is, because with the word tumor versus neoplasm, it may get confusing, and the patient may think that they had a neoplasm or a cancer. So that's when she came to our clinic in August 2015, and she still had persistent discomfort. But this was dull aching pain. This was different from what she used to have, but she still has episodes of severe pain. So in summary, we have the 34-year-old lady with unilateral facial pain tracking back to 5 years. She has history of left chronic sialadenitis that was treated with partial parotidectomy, and she also has left muscle tenderness. When we went through, her medical history, we've already, you can see that there's nothing remarkable here, and she's taking ibuprofen when she has severe episodes of pain. And when it comes to pathology specific history, because the spontaneous onset, she has sometimes associated the pain with headache, clicking on and off. In some examinations, there was note of clicking in the right TMJ, in the others there was clicking on the left TMJ. In another group of appointments, she had no clicking, so that was variable. She also reported paresthesia, especially after the surgery, but it's improving now. So her pain is dull aching in nature, 2 out of 10 most of the time, but twice a week she has these episodes of 8 out of 10 severe pain. So regarding the pain history, I think we already mentioned those, and it's just half of her left side of the face and the left mandible as well. That's the side. Extraoral examination, there was muscle tenderness, and salivary gland palpation resulted in tenderness over the parotid, left parotid, but you can see the rest of the findings are normal. Also, she had right submandibular palpable lymph nodes, but they were not tender, so that could be just a chance finding. Examination for pain and tenderness, you can see that she does have some pain, and they're all quite uniformly on the left muscles of mastication. Which is probably the worst one is the lateral pterygoid when examined intraorally. So we arrived at a diagnosis of temporomandibular disorder. Now, this is a classification of orofacial pain. It's actually the same thing that we've been seeing throughout the presentations. Our patient falls into this category, musculoligamentous, which is temporomandibular disorders, which include the muscle or disc or degenerative problems, which is the same classification that you've seen earlier. So what about the management of this patient? Now, our treatment goals are the same that you've been seeing: managing pain, improving function, and improving quality of life. More importantly, the patient has to understand the chronic nature of their condition, that it wouldn't disappear, especially it wouldn't disappear right away if it disappears at all. And they need to understand that we will be helping them reduce the pain and helping them cope with the pain better. So that once they understand this, they actually show some difference, a change in attitude there. So the management for this case was, we started with conservative management, which is this list, as most of you have seen it, self-care instructions, and if we see that she will need further intervention, we can go on to intraoral appliance construction. So how is our patient now? We actually had one of our colleagues call her 2 days ago, and she said her pain had markedly improved, and she's found the self-care instruction list particularly useful. So that was a change in attitude, and she was definitely happier from when she first visited. So we'll discuss something about chronic sialadenitis and just a bit about Botox as well. So this is an inflammatory disorder, and in this case that was of the parotid gland. It presents with painful swelling that may or may not be associated with eating. The treatment is usually conservative. You can give them self-care instructions, massaging, heat, even sometimes pharmacologic measures have been used, I think salivary stimulation. But with persistent cases, parotidectomy has been described as the treatment of choice for non-specific sialadenitis with intractable symptoms or with those with severe recurrent attacks. This one is safe and effective, and it doesn't have that many long-term complications. So there's no direct association between TMD and chronic parotid sialadenitis, but they may have presented together at the same time, with one following the other, because they're in the same region, and they are both chronic in nature. So maybe the TMD started somewhere along the course of the chronic sialadenitis disease. But asking the patient, she did say that her pain was different when she had that chronic sialadenitis. It was sore, it was tender, her parotids, and it was more severe. But in case of her TMD, although she does get episodes of severe pain, most of it is dull and aching in nature. So what's the role of Botox in TMD? It acts as a muscle relaxant, and they've said it may decrease the release of substance P and glutamate. And what about Botox in chronic sialadenitis? Well, it's been used for the reduction of the swelling episodes to some success, but it's also, always, there's been partial recovery, and it needs reapplication every 3 to 4 months. So in conclusion, TMD is a debilitating disease that can significantly affect the patient's quality of life, and less is often the best in treating TMD, with more emphasis on the patient's attitude and on how they perceive the condition and how they can actually, empowering them that they can actually deal with the pain better on a day-to-day basis. These are our references. I'd like to thank you all for being here and for arranging this, and colleagues and supervisors who prepared the presentation and the other presentations that I learned from. Okay. So if you have any questions, we will try and answer your questions. Otherwise, we can move on to Jocelyn and then lunch.
There is another presentation after.
Yes. Yeah, this one more.
I don't think we can fit it in.
Okay. So you can ask many questions then.
I think it's I think she had a partial
Parotidectomy.
Partial.
Yes.
Partial.
Partial, yes. Partial, yes. Yes.
How does that affect salivary flow? Does the chronic sialadenitis already decrease the amount of saliva, and then Botox
Yes.
more, or is
Yes.
it?
Okay, so chronic sialadenitis is chronic inflammation, and the reason for that, they don't actually know what exactly causes it. They're thinking that there might be mucus metaplasia of the ducts, which are just, their function is just to, transfer the saliva towards the outside. But when there's mucus metaplasia, they produce mucus, and there will be more retention there of the saliva. Any other low-grade chronic ascending infections from the mouth into the parenchyma, into the gland and the ducts of the salivary gland may affect that as well. And as you know, with chronic inflammation, there will be fibrosis. It's part of the normal healing, but it's scar tissue. So the acini will atrophy, so it will become smaller and disappear with time. The ducts will get dilated, and there will be a lot of fibrosis and inflammation there, and that could cause the obstruction. In the last visit before her partial parotidectomy, yes, there was actually no saliva expressed from the duct, so there was almost complete obstruction without obvious cystic or dilated lesions. So that's what it does. The fibrosis there, it reduces the amount of the parenchyma and the salivary flow as well. And because of the limited space of the parotid within the capsule, it can be quite painful when it swells, just like in mumps.
In a chronic sialadenitis, you've got a chronic infection there. Is there something else that you try before Botox? I mean, I think Botox probably have limited long-term effectiveness. I mean, when we're talking about chronic inflammation,
yes.
Is there something else that we could try?
Well, they did try antibiotics, but steroids.
Steroids?
They did try it, but it didn't help yet before the surgery. And especially that she couldn't tolerate the antimicrobials because she had an adverse reaction to gastrointestinal disturbances. So she wasn't very keen on taking antibiotics. Yes, they did try those, but I think
steroid injection.
Steroid prednisone. I'm not sure which. Maybe
Yeah,
I'll know what form.
Steroid injections, because that that'll have an But I guess the issue is it's pretty difficult in retrospect to work out exactly what was going on at that time.
Because this is all under ENT follow-up, so we just get the notes from him.
Yeah, that's right.
And it was it took quite a fair bit of digging into what actually happened, because at the visit we thought it was a cancer. She had salivary gland cancer. And she said she had a tumor, so that's why we prefer to use the word neoplasm when it comes to an actual benign or malignant neoplasm. And the other one was one of the things that Profile is emphasizing on, the familiarity of the thing. So that's what he asked. Is this the same type of the pain that you had before? And she said, no, this is a different one.
Have you checked for the pain referral? If palpating the masticatory muscle, there was a referral to the parotid gland?
Who did the examination?
Have you checked for that?
Yeah, actually, while doing the palpation, basically she still have some tender on the surgical side, but I can say that surgical side is healed well, and but the other region is like she's having mild pain. I don't think it's referred to that parotid.
One of the problem of these patients is that the surgery can really increase the central sensitization that they may have. So really should be the last resource in terms of management.
And the other thing too, when was the surgery? It was the end of 2014, wasn't it?
Yes.
Yeah. So it would have been a general anaesthetic.
Yes.
Yeah.
So
Yeah.
So it could have
Triggered.
well, yeah, not etiologically, but it can trigger something that's exacerbate something that's
And with all the pain that she's been experiencing over past years. Thank you.
The following are 3 case presentations in orofacial pain. This material should enhance your knowledge learned in the facial pain modules. Thank you.